Hello and welcome to this video abstract titled Aerobic exercise with blood flow restriction causes local and systemic hypoalgesia and increases circulatory opioid and endocannabinoid levels. This study was led by Dr. Luke Hughes as part of his postdoctoral work at St Mary's University in London. Exercise-induced hypoalgesia, or EIH, is the acute reduction in pain sensitivity and the perception of pain intensity to a noxious stimulus following exercise. Previous research using blood flow restriction exercise in injured populations has demonstrated reductions in pain following acute and chronic exercise. Indeed, work from our own laboratory suggests this pain may be reduced for up to 24 hours. More recently, we demonstrated EIH in response to resistance training with blood flow restriction, which was greater when higher pressures were used in the exercise leg. However, little is known about the hypoalgesia effect of low-intensity cycling with blood flow restriction, which may be valuable for those who cannot tolerate high-intensity aerobic exercise for long durations. Therefore, the aim of this study was to compare the magnitude of EIH with aerobic blood flow restriction exercise using different blood flow restriction pressures to aerobic exercise at low and high intensities without blood flow restriction. We took 12 recreational males and had them perform 4 different experimental conditions. Prior to this, participants performed a pre-testing lactate threshold and V O2max test in order to determine the exercise intensities for the main experimental conditions. Participants performed cycling exercise for 20 minutes at 75 RPM. The 4 conditions were completed in a randomised order, and they included 1. Low-intensity aerobic exercise at 40% V O2max, 2. Bilateral blood flow restriction cycling at 40% limb-occlusive pressure and 40% V O2max, 3. Bilateral blood flow restriction cycling at 80% limb-occlusive pressure at 40% V O2max, and 4. High-intensity cycling at 70% V O2max. During the blood flow restriction exercise, the cuffs were inflated prior to the beginning of exercise, followed by 3 minutes of inflation and 1 minute of deflation, totaling 5 cycles over 20 minutes of continuous cycling. So what was assessed? Well, we measured pressure pain threshold pre and 5 minutes post-exercise in the quadriceps, trapezius and bicep. And we also took blood samples and assessed beta-endorphin and the endocannabinoid 2-AG before and 10 minutes post-exercise. So what was found? Well, the figure on your screen shows the pressure pain threshold data for the right quadriceps. We found the pressure pain threshold was higher following BFR 40% limb-occlusive pressure, BFR 80% limb-occlusive pressure, and high-intensity cycling when compared to lower intensity cycling. Furthermore, pressure pain threshold was higher following BFR 80% compared to BFR 40% and high-intensity exercise. The previous slide demonstrated what happens to pressure pain threshold locally, for example in the exercise muscles, but what happens remotely? Well, the following is the pressure pain threshold in the bicep, and we demonstrated that the bicep pressure pain threshold was higher following blood flow restriction 80% and high intensity cycling only. We also assessed this remote effect in the trapezius, as shown in the following figure. The only effect observed here was at a higher pressure pain threshold for BFR 80% when compared to low intensity exercise. What about the responses of the blood markers? Well, the change in 2-AG is now shown on your screen, and there were no differences in resting levels for 2-AG between trials. However, circulating 2-AG increased pre to post in all trials except the low intensity condition. These changes were greatest for the BFR80 and high intensity condition. When looking at beta-endorphin concentrations, again no differences in resting concentrations between trials were observed. As with 2-AG, beta-endorphin increased in all conditions except the low intensity condition, with the greatest changes in BFR80 and high intensity cycling. In conclusion, the addition of blood flow restriction to low-intensity aerobic exercise leads to a greater local and systemic hypoalgesia at an exercise intensity which does not typically induce hypoalgesia. Furthermore, the magnitude of this effect is greater and comparable to high-intensity aerobic exercise in the exercising limbs and remote areas of the body, respectively, when a higher blood flow restrictive pressure, for example 80% limb occlusive pressure, is used. Blood flow restriction aerobic exercise activates the endogenous opioid and endocannabinoid systems, which are involved in pain inhibition. However, this may not be the primary mechanism of EIH with blood flow restriction aerobic exercise. The findings of this present study may have important implications for pain management in load-compromised individuals with acute and chronic pain. However, it is important to note that it may not be feasible to engage all patient types in greater discomfort from blood flow restriction exercise for short-term pain relief post-exercise. For further videos on our research, follow us on YouTube or Twitter at Stephen_Pat.